Okay, we could move on with session 3, adolescent pregnancy.
The next moderators, please. We have no pause. The pause is after this session. We can continue now, please. Yes, we have. Yes. Please, Ani Amelia from Malaysia is the next moderator, and Professor Olivera Kontić from Serbia. Please take the seats. Ani Amelia. Ani.
Thank you.
Well, we have to say something about that. Christina.
I often read articles from Karolinska University. It's very good.
So, shall we start? Da se ovo pali. Da. Zorane, gde se pali ovo? Se čuje? Upaljeno? Ok. Možemo počnemo?
Exactly.
Okay, yes, dear colleagues, may I have your attention, please? So I would like to say hello to all of you. Then we should start with our next session. It is about adolescent pregnancy. And on behalf of my co-chair and myself, welcome to this session. Our first speaker is Christina Gamzen-Danielsson. She will speak about medical abortion in adolescents at different stages of gestation. I think it's a very, very interesting topic. Christina is professor of OBGYN, head of the Department of Women's and Children's Health at Karolinska Institute, and senior consultant at the Karolinska University Hospital. So, please.
Thank you very much, moderators, Mr. President, colleagues, new and old friends, and Soran and organizing committee, and my friend Katarina Sedlecki. This is such a nice surprise. I had no real idea about your organization. I knew from Dan Apton. I'm very sorry he's not here, so I'm representing the Nordic countries, I guess. But I think the organization is perfect and with so much heart. So I'm really happy to be here. And also to address my favorite topic. So how do I move my slides? Is it this one? No? So my disclosures, and I wish the list would be longer. We need to collaborate to improve reproductive health. Overview of the presentations. I will talk more about the technical aspects later, but just short background. So, I mean, you are experts on this, and you know that unintended pregnancy is particularly concerning adolescents worldwide. And we know the risks and consequences, but also pregnancy, birth, abortion in teenage years, and well, there is also a higher risk for another pregnancy, birth, or abortion. So we saw a bit of statistics. This is unfortunately old, but it's the latest summary of statistics in the EU member states on teenage births. And you can see also in Europe that we have a huge range when it comes to this. And we know that actually majority of these pregnancies and births are unintended and unwanted. So effective contraceptive methods and safe abortion care are prerequisites for reproductive health. And we should remember the agreement from Cairo in '94 that sexual and reproductive health and rights constitute fundamental human rights and form a vital aspect of women's empowerment, are key to achievement of gender equality, and also to development of society, and of course to give adolescents a chance in life. So I'm very happy about the new WHO abortion guidelines from last year. And what's new? Well, there is a shift, so it's still, of course, containing the more technical aspects on safety, efficacy, but now also stress quality, and incorporates a human rights perspective, and also recommends self-management up to 12 weeks of gestation. Just a reminder, we know there are huge backlashes in many places in the world now, despite all the evidence that we have on this. And we know that the more liberal the abortion law, the lower the risk for maternal mortality and morbidity caused by unsafe abortion. And of course, this also goes very closely linked to access to contraception. Just a little bit, WHO has a website with laws and regulations, but there is also an EU or European website sponsored by Nordic Pharma. And so one thing that I got from that website is age limit for parents or guardians' consent for adolescent abortion. So we can see here that in some countries this is not regulated by law, but in many countries it is, and the age limit varies. So what we just heard for contraception, I think that goes very much also for abortion counseling, to do this in a non-judgmental and respectful way. And we have to consider confidentiality. We have to remember that this may be the first visit to a health facility. If the law requires that an adult gives consent, this should be clearly explained. Of course, it's important to involve someone who can support the adolescent, but we should not insist on parents' authorization if this is not a requirement by law, and it should never delay the abortion. So we have, on top of that, we have many regulations that actually they are clearly not evidence-based, and they just result in a delay of the abortion, so potentially a risk. So criminalization of women, so most abortion laws are within the criminal code. Gestation and age restrictions, consent from parents, as I said, mandatory consultations with counselors or psychiatrists or psychologists, and mandatory waiting periods, multiple approvals, 2 doctor signatures and things like that, regulation on who can provide abortion and where it can be provided, conscientious objection, which is a total misunderstanding. It doesn't have a place in healthcare. In healthcare, it's actually refusal to follow the job description. And it's not a human right to become a gynecologist or whoever is providing the abortion, but it is a human right to have access to abortion. And so on. Mandatory to see ultrasound, and of course it should be offered. If ultrasound is done, it should also be offered to those who want to see it, but it should not, no one should be forced, and also to listen to heartbeats. And then the various requirements related to rape with police reports and so on. So, and the list is much longer. So now we turn to medical abortion, and medical abortion with mifepristone and misoprostol is recommended by the WHO. It's included on the WHO Essential Medicine list, and it's available in more than 80 countries. Misoprostol alone, of course, available in more countries, but now I'm talking about a combined method. And I think that it's important to understand mechanism of action, to use the treatment correctly, but also to explain, because actually, as all gynecologists know, medical abortion mimics a spontaneous abortion. It's exactly the same that would happen if we removed the corpus luteum, which has happened, or corpus luteum insufficiency. So mifepristone acts on the pregnant endometrium, the sidra, to separate it from the uterine wall. It acts on the cervix to cause ripening, dilation, and it works on the myometrium to increase sensitivity to endogenous and exogenous prostaglandins and prostaglandin analogs such as misoprostol. So the innovation of medical abortion actually comes from our WHO center and my supervisor, Mark Bygdeman. His supervisor was Sune Bergström, who received the Nobel Prize for discovery of prostaglandins. And when Mark became gynecologist, they started to use prostaglandins to induce abortion, and very much in collaboration with the WHO. And then mifepristone, or RU486, was discovered in France by Etienne Beaulieu and the company. A great disappointment when it was found to be not very effective when used alone. And that's when Mark came up with the idea to combine the 2 drugs. And that also explains, so you can see here in the figure that a low dose of prostaglandin analog will, during early pregnancy, will increase tonus, but actually this is too low to induce contractions. With a higher dose, there will be contractions, but also more side effects. Treatment with RU486 or mifepristone will in itself induce some contractions, but after an interval, when the myometrium has become sensitive, the same low dose of prostaglandin, as in example A, will cause strong contractions and abortion. So ever since this first description, there's been research, and there is research. So it's what I love with medical abortion is that it's not ready. It's ongoing development, and we need to use it. We need to use it evidence-based. That's so important. Also important to understand is the route of misoprostol. So the dose is important, but the route of administration even more. And so here is illustrated what happens after administration of a single dose of 400 micrograms of misoprostol. There will be a rapid uptake with peak plasma levels, and then decline. After vaginal administration, the peak levels are lower, but the levels remain elevated over a longer time period. So the biologically available substance will be higher. And that will be reflected in uterine contractions. So after oral administration, there is very little contractions, but vaginal administration results in contractions that will continue to increase over time. And if we give, so here you see again, oral, vaginal, and sublingual, which have the most rapid onset. So today the total exposure of mifegyne since launch is 11.5 million of women, with mifepristone line pharma 2.2 million, so 14 million women. This is the Nordic pharma product. In addition, of course, we have Medabon, and we also have women on web and other sources. With medical abortion, this is statistics from Sweden, we see a strong shift that abortions are done earlier and earlier, so now on average 6 weeks. And 97% of abortion before 9 weeks are medical. 100% of second trimester abortions are medical. And we have very few in the interval 9 to 11 weeks. I think you are familiar with the dosage that we use, 1 tablet of mifepristone, and then after an interval, misoprostol. An initial higher dose and then repeated doses every 3 hours, depending on gestational length and effect. Pain medication is crucial. RH prophylaxis is no longer recommended during first trimester. General antibiotics is not recommended, and the same dosage is used irrespective of BMI. The interval, so the optimal sensitization of the myometrium is seen after 36 to 48 hours. However, in early pregnancy, it's actually enough with 24 hours, and that will give less side effects. When we move in gestational length and in second trimester, it's possible to reduce to 24 hours, but that will require an additional dose of misoprostol. So we try to keep 36 to 48 hours to reduce the dose of misoprostol and side effects. Pain treatment, so NSAIDs are the basic, and we add paracetamol to strengthen the effect of NSAIDs. We also give opioids in a low dose. That's also for women who take the medications at home. And for those who stay in the clinic, we use, and in second trimester, we use a lot of paracervical blockage. Importantly, NSAIDs were contraindicated from start, but we have shown clearly that they does not affect uterine contractility, cervical ripening, or induction to abortion interval in general. But actually, in teenagers in second trimester pregnancy, they reduce the induction to expulsion interval. So pain medication, extremely important. There are very few contraindications to medical abortion, and as I said, in second trimester, there are no contraindications. It's highly effective, 98 to 99% efficacy. There 0.5% ongoing pregnancy, 0.5 to 2% incomplete abortion. Bleeding volume, I think this is interesting because the median is 75.5 milliliters up to during the first trimester, which is actually less than a heavy menstrual period. And duration, 10 to 14 days versus vacuum aspiration for similar gestation lengths, so very similar. In very early medical abortion, it's actually much less. And then very few requires any intervention within 4 hours after misoprostol, and that was, of course, why home use became possible. Potential side effects, pain, and compared to menstrual pain, you can see here bleeding. Also, we compare to menstrual pain because then it's easier to understand and to know what to expect. Counseling is extremely important to know what to expect, and this can usually be managed by the woman herself. But earlier, the less side effects. It's important to be informed about symptoms that should prompt contact with healthcare. And surgical intervention is usually not needed and should not be based on the ultrasound finding. So, highly effective, highly acceptable, and has really helped to empower women globally. And how can we increase access to high-quality, safe abortion care? So we have looked at home use of misoprostol, task shift from doctors to midwives to women themselves, simplified procedures for follow-up, expanding access from very early to much later. We know that the same method can be used, so it's just a legal limits, no medical. Post-abortion care, I won't have time to talk about that, and telemedicine or self-management. So in many parts of the world, D&E is still standard for second trimester abortion, while in the Nordic countries and increasingly in Europe, medical abortion has become standard. And the same regimen as we used for the early medical abortion, it's just that we need to repeat misoprostol. And usually we give it sublingual because if there is bleeding, uptake will be poor. I'd like to stress here that less than 10% need a surgical intervention because of incomplete placenta. But this is a learning exercise, but important, and most can be managed as day cases. Complications and side effects to the pregnancy itself, of course, increases with increased gestational length and increased doses of misoprostol. That's why we try to limit the doses. Uterine rupture, we have to be aware if there is previous surgery and maybe reduce the dose of misoprostol. And side effects, as I said, are very few. Post-abortion contraception should be remembered and offered at the time of the consultation. Otherwise, it's too late. We should not wait until a follow-up. And it's possible to quick start with implants that can be inserted right after mifepristone. There is no interaction. IUDs, all types, can be inserted after expulsion or within the week after medical abortion. There is no increased risk for complications. So I just wanted also to say something on telemedicine. So we did the first evaluation of women on web, and we saw that it was as effective as when offered in the clinic. And initially, of course, this was for women living where legal abortion is not available. When we published the first publication, I thought that everyone would be happy for this option, but most people turned against it. And there were headings like in the Telegraph that women risk health by using abortion websites. Now, many years later, you can see the same journal they publish on lifestyle, abortion pills, everything you need to know. So, of course, there's been a huge shift. And it's not only for women where abortion is illegal. The COVID increased demand in US and in Europe. And FIGO endorsed the continuation of telemedicine after COVID. Ooh, yes. Oh, this was very strong. We have the Scottish model, we have the UK model, which is not website, but telephone consultation. And here it's registered data, so it also includes teenagers. And I just wanted to conclude with Italy. During pandemic, we looked at women using women on web, and we looked at a subgroup of teenagers. And we can see that teenagers, they do the request at a later gestation with a higher prevalence of rape and less access to healthcare services. So they really deserve attention also when they use websites. So a lot of conclusions here, but I think it's important to maintain choice. And we can use medical abortion from very early to much later. It's a continuous development. It's safe also for teenagers. There's no difference. It's just that it's important when it comes to teenagers, even more important with the teamwork, with doctors, midwives, youth clinics, school nurses, etc. And this was the last slide. Thank you very much.
Thank you very much, Dr. Christina. It's with great pleasure that I introduce the next speaker, Dr. Charlene Shung from Queen Mary Hospital in Hong Kong. So she won the Young Gynecologist Award of Asia Oceania Federation of ONG in 2019. Charlene is also the current board member of FIGIC and founder of FIGIC Social Media. It is with great pleasure that I introduce her to give a talk on adolescent pregnancy and child marriage.
Thank you very much, Amelia, and thank you, everyone. Good afternoon, friends and colleagues, ladies and gentlemen. It is my great honor and pleasure to see all of you physically again at World Congress. And I would like to thank Zoran and Paul. Thank you very much for giving me this opportunity to share this talk today. And thank you, Zoran, for your thoughtfulness and hospitality over the past few days, and this is really a great conference. So today I'm going to share with you about adolescent pregnancy and child marriage. I have no conflict of interest to declare, and this is the outline of my talk today. I'll be looking through the issue of adolescent pregnancy through a global lens. We'll be identifying contributing factors and consequences of adolescent pregnancy. We'll also touch on child marriage and how we as PAG specialists as a group can help combating these two issues, major obstacles to adolescent health and well-being. The World Health Organization has already addressed that adolescent pregnancy is a global phenomenon that with clearly known causes, and it leads to serious health, social, and economic consequences. According to the data between 2015 to 2021, globally, 1 in 6 adolescent girls and young women reported giving birth before the age of 18. That translates to 21 million adolescents aged 15 to 19 and 2 million under the age of 15 becoming pregnant each year. The United Nations also reported that 20,000 girls aged below 18 are giving birth every day in low-middle income countries. Now, this number is highly variable by the country and region where the girls live and the background income and education. So here's the distribution of global adolescent birth rate as of 2021. The rate was about 2 births per 1,000 girls aged between 10 to 14. And for some regions in Africa and South Asia, the numbers are really lacking. And it's postulated some of these birth rate might be exceeding 10 per 1,000. And this is similar distribution for girls aged between 15 to 19. And the rate was about 43 births per 1,000. And we can see that here in Europe and North America, the rate was lowest, whereas the higher rates were in sub-Saharan Africa, in the Eastern, Southern, Western, and Central Africa, where the birth rate was exceeding 25%, which is more than double of that in South Asia, where the rate was 1 in 10. But the good news is, since the year 2000, the global adolescent birth rate, especially for the group of age 10 to 14, has dropped remarkably by over 50%. And this drop is also similarly seen for the age group 15 to 19, dropping about more than 30%, from 65 to 43 per 1,000. However, it is worth noting that this doesn't translate to an absolute number because during the same period, in fact, the population of adolescent girls in Africa has been increasing. Now, the numbers we've covered were only those who gave birth. The actual number were significantly underestimated because a lot of pregnancies were unintended, and majority of them actually might end up in abortions. So it's estimated that each year, 3.9 million unsafe abortions occur to girls between 15 to 19 in the age in low middle income countries. And you can see from this chart, which is about 10, 20 years ago, still the number varies widely across different countries due to their culture, policy, as well as religious background. And there are a lot of inconsistent and incomplete data causing underestimation of the actual situation. Now, I would like to bring to you this slide, which I think would summarize the key contributing factors causing adolescent pregnancy. First and most important of all is poverty and income inequality. That leads to lack of opportunities for girls to complete education and vocation, and they drop out from school. On a parallel note, there is also gender inequality affecting girls mostly and disproportionately. They are the victims of neglect, coercion, and sexual violence, and many of them face the risk of unprotected intercourse. And because of social pressure, they tend to marry or even end in forced marriage early. The lack of education and information about appropriate sexual reproductive health and their rights make them vulnerable, and they cannot access to appropriate and needed tailor-made service for contraception and pregnancy. Now, on a different level, our society overall, are we having a changed social attitudes and allowing greater acceptance of for adolescent sexuality? That's also something to think about. The consequences of adolescent pregnancy are multifaceted. And there's no doubt that pregnancy changes the life of an adolescent girl radically. Because these girls become pregnant, they become mothers while they are still children themselves. They are not only physically not ready, they are psychosocially also not ready for pregnancy and motherhood. The fact that they come from lower income background make them nutritionally depleted, and their lower minimal education level also make them socially deprived from choices and resources for necessary care. In turn, it leads to more vulnerable to complications. And the charts from UNICEF data show that globally, maternal conditions are still among the top causes of morbidity and mortalities among adolescent girls. And every year, 70,000 girls died because of this. And the risk of mortality associated with pregnancy is 1/3 higher amongst girls aged 15 to 19 compared to 20 to 24 years old. As obstetricians and gynecologists, I think we are familiar with the complications related to adolescent pregnancy. Just to name a few: maternally, preeclampsia, obstetric fistula, puerperal endometritis, and infective comorbidities. IUGR, prematurity, low birth rate, birth asphyxia, and neonatal health problems. Pregnant adolescent women or young women receive fewer antenatal visits, skilled delivery, or postnatal care. Researchers also show that they are at higher risk of postpartum depression when we look at adolescents aged 15 to 19 compared to those who are older. It's 2 times higher. And very often we overlook the psychological impact of accidental pregnancy and abortion. As we mentioned, a lot of them might end up in unsafe abortion, which leads to long-term complications including pelvic inflammatory diseases, chronic pelvic pain, ectopic pregnancies, and subfertility down the road. In many parts of the world, contraception still require parental consent, and as we've discussed, and even if they do not need parental consent, confidentiality is an issue. Adolescent pregnancy is also associated with background high-risk behaviors, namely smoking, alcohol use, drug abuse, and sexually transmitted infection. It is found that for unmarried girls 15 to 19 years old, they have higher risk of multiple sexual partners and repeat pregnancy compared to those who are unmarried at the age of between 20 to 24. And those who have been pregnant before are likely to becoming pregnant again while they are in the adolescence. Now, because the session covered adolescent pregnancy, abortion, as well as STI. I would like to share with you some of the data in my hospital which I collected. I work in the university-affiliated hospital tertiary center in Hong Kong. So before COVID, this is a 10-year review of all the patients, teenagers admitting to us for legal terminations. We have more than 400 legal terminations for adolescents aged 18 or below, constituting about 8% of our total terminations over the years. And then of note, 14% were at the age between 13 and 15. And for your information, it is unlawful to have sex before the age of 16 in Hong Kong. Among them, 1 in 5 had previous termination of pregnancy, and 10 girls had repeat terminations within our review period in the same hospital. Nearly half of them did not use any form of contraception, and half of them were ever smokers. I specifically look at STI because in our hospital, we have been screening all women coming in for requesting termination of pregnancy, and we screen for chlamydia because of the high-risk profile. And the background risk of these girls having previous STI was about 5.7% and mostly having chlamydia before. And among those whom we've screened, 29% were screened positive for chlamydia, and among them, 16% were positive for more than one STI. Now, giving you the background information, in Hong Kong, a survey published a few years ago, the population risk of women having chlamydia was about 1.4%. And in sexually active young women between 16 to 26, the risk was 5.8. So you can see that in this group of adolescents with high-risk behavior, the risk was 5 times higher. Socially, these young girls, when they got pregnant, they have self-blame, shame, and they also receive stigma from others. And they often face rejection by their peers, family, or even their own parents. And we know that adolescent pregnancy is associated with physical and sexual violence within their partnership and even young marriage. They have school dropout. They could not reach their education attainment and full potential. They have restricted lifetime earning prospects. And as a result, for the society, there is increased risk of unemployment, social welfare needs, and higher level of poverty. And we are all bearing the cost of managing these long-term health consequences, namely reproductive health treatment and mental health issues. And now we move on to child marriage. By definition, this is marriage or union with either or both spouses younger than the age of 18. So some facts. As of today, more than 650 million young women were married or in an informal union before their 18th birthday. Majority happened in sub-Saharan Africa, South Asia. And as many as 90% of births to girls aged between 15 to 19 in developing countries occur within early marriages. Child marriage deeply affects child brides, their children, their family, and even their countries. This is rooted because of inequality of power, disproportionately and negatively affecting girls. So this is, you can see from this map, the areas where still have high child marriage is highlighted in pink, and the rate can be as high as more than 50% or up to 70%. On the right-hand side, you see the bar chart, which show that, in fact, majority of countries had a decrease in the rate, but there are still a few that still are on the rise. Now, there are several things we need to know about child marriage. I'll just highlight the important ones. No country is unsusceptible to child marriage. And the problem is it often arises in humanitarian settings, as we've seen in the map, areas where there are famines or internal conflicts, warfare. And it is very costly to manage child marriage because they cost the country a lot of money, a lot of resources, and this in turn would also increase the demand from external assistance from other countries. But it is also surprisingly affordable to stop them. Empowering girls is crucial. Now, I'm not going to repeat those risk factors and consequences of child marriage because they are very similar to adolescent pregnancy. I'd like to highlight and emphasize again, these girls, very sadly, do not have the ability to have choices, and they are also deprived of opportunities. Now, I'd like to share with you this real story in Southeast Asia. This is a 14-year-old adolescent who got pregnant. Her boyfriend, 4 years older, got her pregnant as a mark of ownership. The girl resisted, but he persuaded her to have sex. And by the time she gave birth, he was in jail. And she was raising the baby with the help of the man's mother. So these are the exact phrases or expression the girl said to the interview. And her life has never been the same. Pregnancy and motherhood are human rights. And over the past decade, there has been a lot of global advocacy and partnership to end child marriage. And indeed, 25 million child marriages have been prevented in the last decade. But we can do more. However, COVID hits us. The pandemic halted the progress that we've made, if not made the situation worse. There is lack of countrywide surveillance and data gaps during the pandemic about adolescent pregnancy and child marriage. And according to a study published by a Bangladesh group, there's report about dramatic upsurge in the prevalence of underage marriage, unintended pregnancies, and gender-based violence because of strict lockdown, school closures, service interruption, security concerns, religious, and the parents die because of the pandemic. The poverty aggravated. So it squeezed on the already underfunded health services because of the pandemic. And now we are moving on after the post-pandemic era, and what can we do? Now we need a holistic approach, and we should start from the root of the problem. That is, we should invest in girls' education, including age-appropriate sexuality education. We should support girls' rights and empower them. Men and boys should also be engaged in building gender-equitable societies. Ban child marriages. Adolescents should also be provided accessible and affordable health services, including contraception and pregnancy care. And now we are already moving on from Millennium Development Goal in 2015 to Sustainable Development Goals in 2030. So we want to achieve gender equality and empower all women and girls. We need to reduce adolescent pregnancy rates. So we cannot emphasize more about addressing the root causes, mitigate the risk, and protecting the future of our young girls. And here I would like to draw your attention to our Fiji statement, which is written by our Fiji Advocacy Working Group. There's a call to minimize risk of adolescent pregnancy through education and contraceptive access. Fiji supports the comprehensive sexual and reproductive health education. We advocate access to youth-friendly health services, including affordable and safe contraception, such as emergency contraception and LARC. We also support the development of comprehensive programs, prenatal, postnatal care, education, and we need socio-economic support to optimize adolescent health and well-being during and after pregnancy. So with this, I'd like to conclude that child marriage and adolescent pregnancies are closely related global phenomena. They change the life of adolescent girls drastically, leading to health, socio-economic, and economical consequences. Empowering girls by education, provision of accessible, affordable contraceptive services and pregnancy services are essential, and we need socio-economic support in optimizing their well-being. Before I end the presentation, I would like to welcome you all to join us on our social media. And I would like to take this opportunity again to thank all friends in the Fiji board. In the past 3 years, it's been a really rewarding and wonderful experience learning from all of you and working with all of you. I would like to also thank my trainers, Dr. Simferosa Chan and Professor Sonia Grover, for their support and guidance during my PAG training. And I thank all of you, colleagues and friends all over the world, along the way of our PAG learning and services, and we shall continue with that. Last but not the least, our Hong Kong College of Obs and Gynae is celebrating our 35th anniversary this year. So we are pleased to invite you to our international conference that will be held in late November this year. You can refer to the website for further information. And please save the date, and we look very much forward to welcoming you all in Hong Kong. Thank you. Thank you very much.
Thank you very much. Now Andrea Cuneus Vergara, Professor of OBGYN from Santiago, Chile, researcher, educator, clinician, and advocate for young women's reproductive health, will speak to us about addressing STD in adolescents. Can we do better?
Okay, good afternoon. Today I'm here to bring you good news because we have today, on May 18, 2023, all the means to eradicate sexually transmitted infections. So in this conference, we will talk about the toolkit that we have in our clinics of all those means that science has given us to tackle sexually transmitted infections in adolescents. My name is Andrea Cuneus. I come from Chile. I'm the past president of the Chilean Pediatric and Adolescent Society there, and I want to thank this wonderful invitation and this wonderful opportunity to share this information with you. Chile is this little country in the south of South America. I have no conflicts of interest. And our agenda for today is we're going to talk about prevention, we're going to talk about screening, and we're going to talk about treatment. So sex education. Sex education is protection. When young people do not receive adequate preparation to deal with their sexuality, they are potentially vulnerable for abuse, exploitation, unintended pregnancies, and sexually transmitted infections. And sex education works. Dr. here was talking about what do we do about the backlash that's going on with sex education. Well, we have all the information. We have all the research on our back to tell us that multiple studies have compared youth who received sexual education with those who did not. And those who receive sexuality education delay sexual debut and use more protection. This is one of the multiple meta-analyses that we have. If adolescents receive sexual education, they have 30% reduction on sexually transmitted infections. So evidence is a tool for this backlash that is going on with sexual education today. Vaccines. Hepatitis B. Today we have the good news that newborn vaccination of hepatitis B has a 90% global coverage, and that's amazing. In our country, my country, it started in 2006, so 17-year-olds and under are vaccinated in Chile. In the US, for example, it started in 1991, so 30-year-olds and under are vaccinated. So I ask you the question, when did hepatitis B vaccination started in your country? And this is important because we have to prescribe hepatitis B vaccine to all. So to all previously unvaccinated children and adolescents, and to all over 18 and risk. And who are over 18 and risk? Young people or people with multiple sex partners, men that have sex with men, injecting drug users, household contacts of people with chronic hepatitis B, diabetes, people that consult on STD and HIV clinics, or correctional facilities, and we'll talk about PEP a little bit later. HPV vaccine, we had this wonderful symposium earlier that gave us this good news that I won't repeat, that HPV vaccine programs have already started all over the world. And WHO gave this statement on December and stated that one dose can be okay, the WHO now recommends 1 or 2 dose schedules for girls from 9 to 14 years, 1 or 2 dose schedules for girls and women aged 15 to 20, and 2 doses with a 6-month interval for women older than 21 years, with this little yellow remark here about immunocompromised individuals and living with HIV, that they should receive at minimum 2 doses and where possibly 3 doses. Right after this came out in December, the European Society for Gynecological Oncology came up with this committee opinion about the single dose of HPV and thinking if this was enough or not. And they researched all the evidence, and they made a beautiful, beautiful article about all the evidence that the WHO made to make this recommendation. And they put the final talking points of this articles are the ones that I give you here. So single dose is better than no dose, okay? That's totally clear. The data of the non-inferior clinical protection of single-dose regimens are not yet available. So what we have, the current data now, is just immunogenicity. So we need more clinical trials to show clinical efficacy. But a single-dose regimen may be particularly relevant in countries that have not yet started routine HPV vaccination because of lack of resources. So again, prescribe HPV vaccination to all previously unvaccinated children and adolescents. Know your cohorts, okay? In Chile, we have HPV vaccination for 9-year-olds that started in 2014 for girls. So our girls are vaccinated, all the under 18 are vaccinated. Our boys, it started in 2019 for boys, so all the boys under 13 are vaccinated. And there's HPV special vaccination programs for HIV, immunodeficiencies, oncological patients, chronic diseases, and PEP that I'll explain later. So continuing with prevention, we're going to talk about condoms, and this is a subject I like very much. So condoms prevent STIs. This is no news to you. And of course, I wanted to show a little validation study of that huge subject that we all know very well that we did in our country. And this is a cohort of 400 adolescents where we studied chlamydia. And in the survey, we asked them, and 87% of the adolescents, they were boys and girls, 50-50, said they ever or sometimes use condoms. Of those in the part that said ever or sometimes use condoms, 10% had chlamydia, boys and girls, and they were similar in girls, boys and girls. And the ones who answered the survey and said that they always use condoms, none of those had chlamydia. So that's our little Chilean validation study of the efficacy of condoms in preventing STIs. Condom use has a social determinant, is also determined by social factors. This is a study, a population-based study of adolescents in Chile, and the survey that was population-based that went to all of a sample, a epidemiological sample of Chile, was asked to all the adolescents in Chile, and here we were trying to find the difference in the social determinants of health and condom use. And in Chile, about 70% of children go to these public schools that are free, and then there's a percentage, around 30%, that goes to these charter schools that are cheaper, and then there's less than 10% that go to private schools that are expensive schools. And condom use was determined by this social determinant of health, that is the type of schooling that they had attended to. So adolescents in their first sexual debut, 30% of adolescents use condoms in public schools, 52% adolescents use condoms in charter schools, and 60% of adolescents use condoms in private schools. So we have to address these inequalities to tailor our education of condoms and all the tools we have to uptake to improve the uptake of condom use. So clinicians, we have a role helping adolescents improve the use of condoms. And for example, we'll talk about the 3 points. So let's have ubiquitous, universal, free access in schools and houses of adolescents. And what do I mean when I say houses? When you have a parent in front of you, a parent of an adolescent, as I am in that picture, I'm talking to a parent and telling me, you have to have a jar inside your house full of condoms that you fill every time it's emptied. And the adolescent will take the condoms and nobody talks about it. But you have to help adolescents access condoms because it's very hard. They were talking, doctor was just talking how hard it was for him to buy a condom when he was an adolescent. So as parents, we have to empower parents and give this little treat to them because parents are very preoccupied about sexually transmitted infections and they will tell the kids, oh, you can't get those, but then they don't know what to do. So we have to give them this tool. Have your condom jar somewhere hidden where your adolescents know where it is. And also as clinicians, we have to help adolescents improve their condom experience and to teach them how to use barriers for oral sex. We'll talk about that. Improving the condom experience. Okay, so teach your adolescents how to choose a condom. The importance of a condom, of a comfortable condom, is not the length of the condom, it's the width. You know, the width of the penis. The condom has to be the same width of the penis to be comfortable. And for that, this number called the nominal width. And the nominal width is this. Imagine this is a penis. It's not a penis, but I'm just teaching you. And it's the circumference of the penis that you can measure with a little rope like that. With this, you have the circumference of the penis. And when you divide the circumference in two, you have a number. Okay, and that number is always between 69 to 47 millimeters. And that number is always there in every condom package. You will, if you look at the little letter, it'll say the nominal width of every condom. So the owner of the penis knows its nominal width. Okay? Also, talk about latex and polyethylene because polyethylene condoms can give you a very different experience. So sometimes if you use latex, it's not the same as if you use non-latex condoms, so make them try. Also talk about lubricants. You know, condoms, they dry up, they swallow the natural lubrication. You have to use condoms with lubricants, so you have to address this issue when you're counseling about condoms. And also recommend internal or vaginal condoms because they give a different experience and they may be a different way of, maybe the way you can feel it in coitus is different. So just recommend them to try it because it could be another option. Teaching barriers for oral sex over a penis, always use condoms. Barriers for oral sex are on vulvas, use always oral dams. This is an oral dam. It's traveled a long time, but it's a long way, but from Chile, but there it is. You can cut a penis condom in half and have an oral dam, for example, like this. You just cut it and you straighten it, and there you have an oral dam to give oral sex over a vulva. That's a way to do an oral dam. And the other one, you may know this one, using a glove. You cut the fingers out. Then you cut the other side where the small finger is of the glove. And there you have a beautiful oral dam with a space for the tongue. So we'll go straight to PrEP. Prescribe PrEP in high-risk adolescents. Who needs to use PrEP? If you are a woman that has sex with, or men that have sex with men, or women that have sex with men that have a positive HIV partner, multiple sexual partners, or irregular condom use, recent STI, sexual partner at risk, or a personal decision. You have to put this in the toolkit and prescribe it because prescribing it is simple. PrEP is approved for minors that weigh over at least 35 kilos. This combination, you may pronounce it, the name is Truvada, is approved for adolescents. There's new combinations coming over, tenofovir and emcitrabine, and the you pronounce it. That is an intramuscular PrEP that comes every 2 months. So these are the news that are coming, but they're not yet approved for adolescents. And PrEP can be used daily, especially that's what we use in girls, but also can be used on demand. And on demand is 99% effective for anal sex. So on demand is 2 pills during the 2 hours previous to sex, 1 pill after sex, 24 hours post-sex, and 1 pill 48 hours post-sex. And that's just as effective for anal sex. Prescribing PrEP is simple. It's very simple. Don't get complicated. It's nothing hard. We prescribe contraception. That's hard. Discuss PrEP in the pre-prescription visit. Perform the labs. The labs are HIV, STI screening, and you have to do renal and liver function and a pregnancy test, of course. Then the next visit, you just prescribe the test, when the PrEP. The next visit, the first clinical follow-up has to be in 30 days, and then you follow up every 3 months with the same labs, repeating the labs, okay? That's the only thing that it takes to prescribe PrEP, so please prescribe it. But PrEP can decrease bone mineral density, especially between 15 and 19 years old. There's an unclear significance related to of that information related to fractures, and we have to have a patient-related discussion about bone health and HIV risk. But this is something we have to know about with our patients. So PEP, post-exposure prophylaxis. We have to know how to prescribe post-exposure prophylaxis. And post-exposure prophylaxis can be post-sexual abuse or just post-exposure, sex that you didn't want to have or risky sex that you have. It doesn't mean only sexual abuse, okay? It means whatever exposure, you have to have this toolkit to help your adolescents. So first, hepatitis B. Unvaccinated should receive a vaccine and hepatitis B immunoglobulin. Previously vaccinated should receive a single booster use. HPV vaccination, don't forget it, if not or incompletely vaccinated, started there in the post-exposure moment. And the regimen for adolescent and adult females of antibiotic is ceftriaxone 500 milligrams intramuscular and doxycycline 100 milligrams 2 times daily orally for 7 days. Also add metronidazole orally 2 times a day for 7 days. And the recommendations for HIV PEP are made on case-by-case basis according to the risk, okay? The easiest formulation is Acryptega, and it's got those 3 medications that you see there. Other regimens are available per kilo in pediatric population. The effectiveness for HIV PEP is if you started before 72 hours. If you started after 72 hours, it doesn't work. And the risk is high in receptive anal sex with ejaculation. The risk is medium in receptive or insertive anal sex, receptive anal sex without ejaculation, and the risk is very low in oral sex. So those are the things that you have to discuss to your patient when starting it. Screening. STI screening recommendations in sexually active adolescents, chlamydia yearly, considered rectal samples. We're going to talk a little bit about that. Every adolescent seeking evaluation for any STI or treatment for any STI, any pregnant adolescent. HIV, all. Every time you take a blood sample out of any adolescent, please ask the option of taking an HIV test. And of course, every adolescent seeking evaluation or treatment for STI. And if you are planning or advocating to implement a screening program in your country, as I am, because that's what I'm currently advocating for in Chile, please implement screening programs with self-collected samples. Adolescents prefer to collect their own samples for STI testing. This is a study we did also in a country to validate that information. Adolescents don't like anybody touching their genitals and taking samples of them. And self-collected samples are self-collected vaginal samples or self-collected urine samples. So please implement screening with self-collected samples. And what are the treatment news? We have this news from last year, well, 2 years ago. Chlamydia is treated with doxycycline now. So doxycycline is the recommended regimen, and azithromycin went down to alternative regimen, and so did levofloxacin. And why did that happen? Because of microbiologic treatment failure that is higher for azithromycin than for doxycycline. Chlamydia is detected in the rectum among 33 to 83% of women with that have urogenital infections. And detection is not associated with the report of receptive anorectal or sexual activity. And also, there's about 30% of women that do not have a urogenital infection that have chlamydia in the rectum. So this complicates, that's why I put this phantom here, this scary situation. And doxycycline is more efficacious, 100% for rectal infection than azithromycin. So that's the reason we're taking doxycycline now. Not because resistance of azithromycin, it's because of the rectal infections. And gonorrhea is treated with ceftriaxone 500 milligrams now, not 250, and that is due to the increasing minimum inhibitory concentration of ceftriaxone over gonorrhea. So this is what the toolkit I wanted to show you. This is the summary, prevention, sex education lowers STIs, vaccines, hepatitis B, HPV to all. Barriers, teach how to improve the experience, please. PrEP, prescribe. PEP, prescribe it. Screening, routine, chlamydia, HIV, and the treatment news about doxycycline and ceftriaxone. Thank you very much.